A severely septic patient in the ICU has hypoxemic respiratory failure. The chest X-ray shows bilateral diffuse opacities. What do you see on this chest X-ray?
The chest X-ray shows a PA view of an intubated patient with bilateral hazy opacities in the middle lung fields, mild pleural effusions, and air bronchograms. This X-ray could be consistent with ARDS or pulmonary edema.
How do you differentiate between the two?
It is often difficult to make this diagnosis. In this case, the clinical history is more suggestive of ARDS. The infiltrates are present peripherally, and there is no cardiomegaly, also favoring ARDS. Finally, there are no curly B lines, and the pleural effusion is small and one-sided, which goes against pulmonary edema.
How would you set the ventilator parameters?
Suspecting ARDS, I would start with volume control ventilation with a tidal volume of 6 milliliters per kilo of predicted body weight. I would then titrate the PEEP and FiO2 to maintain an oxygen saturation of 88 to 90%. Finally, I would set the respiratory rate to a value which allows the plateau pressure to remain below 30 centimeters of water and minimizes PaCO2.
What is a plateau pressure?
The plateau pressure is the pressure applied to small airways and alveoli. It is measured during an inspiratory pause on the ventilator and reflects lung compliance.
The pulse oximeter shows a saturation of 80%. What do you do?
First, I would perform a recruitment maneuver. Then I would incrementally increase the PEEP and FiO2, attempting to keep plateau pressures less than 30 centimeters of water and FiO2 less than 70%.
How does PEEP help in this patient?
Increasing PEEP in ARDS keeps alveoli open to participate in gas exchange, decrease shunting, and minimize shear forces associated with repetitive opening and closing of alveoli.
The pulse oximeter now reads 89%. With 6 milliliters per kilogram tidal volume, the plateau pressure is 35 centimeters water. What is your next course of action?
I would try to reduce the plateau pressure to below 30 centimeters of water by decreasing the tidal volume to 5 milliliters per kilogram. If the plateau pressure decreases with this maneuver, I would check an ABG.
The ABG shows a pH of 7.11, a PaCO2 of 64, PaO2 of 65, and an FiO2 of 50%. How severe is the ARDS?
The PaO2 to FiO2 ratio in this scenario is 130. This is compatible with moderate ARDS.
How do you correct the acidemia?
I would increase the respiratory rate to obtain a pH greater than 7.3.
How much can you increase the respiratory rate?
I would gradually increase the respiratory rate up to 35 breaths per minute, but only if plateau pressure remains below 30 centimeters of water.
You gradually increase the respiratory rate to 35, and the pH on the next ABG reads 7.14. What do you do now?
I would increase the tidal volume gradually to a maximum of 8 milliliters per kilogram. If needed, I can decrease the PEEP to minimize the potential for barotrauma, since the PaO2 is adequate at an FiO2 of 50%.
The patient is still acidemic. What else can you do?
I could use bicarbonate or THAM to help correct the acidosis, though I would only correct to a pH of 7.2 with these agents.
Why not use bicarbonate earlier or more aggressively?
Bicarbonate is associated with sodium and fluid overload, as well as an increase in lactate and PCO2. It also causes a decrease in serum ionized calcium and an intracellular acidosis. Moreover, there is no proven outcome difference with its use. Therefore, I would use it as a last resort.
After 5 days, the respiratory status of the patient has improved. How do you wean the patient off the ventilator?
I would use the weaning protocol most commonly used in my institution. For example, I would decrease pressure support and FiO2 to minimal settings, such as 5 centimeters of water and 40%. Then I would perform a spontaneous breathing trial for 1 to 2 hours,